till we get a questions, I will like to sum up in a way like allergic rhinitis is the central part in allergy diseases, and it is just not a nose is not just a part of the face actually. In allergy, as I mentioned, the nose mucosa which is connected and this persistent inflammation which continues with the newer sensitivities, even in spite of the localized symptom management, because many of in our country many of the people go for alternative therapies and all, some of the symptoms are controlled and they feel like it has been cured, but it is not a lower immunity, it is a hypersensitivity disease, and once allergy is always allergy till we don't manage it properly. So scientifically evidence based research based therapies should be utilized, and not only just symptom wise, but the allergy should be managed with the proper allergen identification, some simple precautions, then monitor the patients afterwards also, because many of them patients are going into skin problems, food allergies, rhinosinusitis, obstructive sleep apnea, adult asthma, chronic respiratory diseases as COPD, which is the second death causing disease in India. And considering the dust which is increased because of the global warming and increase into the pollens and severity of the disease, which is already causing a lot of morbidities and complications into the patients, the scientifically the hypersensitivity should be considered in spite of the symptomatic control. The newer sensitivities continue with the minimal persistent inflammation. So to manage that, even suppose the symptoms are controlled, always get a expert advice, continue with the nasal steroids for a longer period also depending on the season. Does not matter, it will definitely helps to the patients.
Thank you, sir. So one of the questions we've gotten is that you mentioned minimal persistent inflammation. Could you elaborate on the same?
See, it's I always give an example. Suppose a diabetic patient with a diabetic retinopathy goes to the ophthalmologist, he treats the diabetic retinopathy, but he will always refer to the diabetologist. So underlying sugar into the body and the other organ involvement can be there. If it is missed, the patient will have a neuropathy and the kidney damage and other complications. The same way in allergy, it has been found that the patients have a minimal persistent inflammation into the body. So it always it's like a tip of iceberg. The symptoms are like rhinitis or bronchitis are like a tip of iceberg. The inflammation continues, and what happens here, the newer sensitivities are continued into these patients with the multiple pollens, dust mites and insect droppings, pigeon feathers or bird feathers, molds, and it does not show up the symptoms. And then it's like a heart attack also. Like suppose somebody has a blockage of 40%, he may not show symptoms. And somebody maybe at the age of 45, 50 has a severe heart attack when it is detected 90% blockage. The same way here, this persistent inflammation continues for many years also together. And one fine day, the patient gets a trigger because of the dust, smokes, or some lifestyle change, or some additives into the foods or something, or change in weather, and severe symptoms are there, not only from the same part, it may be from the any other body parts or even the food allergies or anaphylaxis also, or severe drug allergies also. So that is the minimal persistent inflammation which continues into the body.
Thank you very much, sir. And we've discussed allergic rhinitis complicated with asthma or asthma complicated with allergic rhinitis. Similarly, how would you approach a patient having allergic rhinitis complicated with atopic dermatitis?
Actually, as I mentioned, allergic march. So most of the children, they have a atopic dermatitis or eczema in the childhood, infancy. It is overcome, then they go into rhinitis, then it is maybe many of the children overcome it, then they go to asthma, many of them overcome the asthma, go to again rhinitis, rhinoconjunctivitis, rhinosinusitis, deviated nasal septum, obstructive sleep apnea, then adult asthma, COPD. And reverse also, some of the patients we have found that they present with the rhinitis in the childhood and then they go into adolescent or toddler eczema or atopic dermatitis. So it's all connected and the allergy continues. So these are all comorbid conditions. So that's why I mentioned that we have to manage the allergy so that this should not happen. So even the children infantile eczema, 50% of them are going into rhinitis or rhinoconjunctivitis or asthma. So there is a allergic march.
Thank you, sir. And any particular diagnostic tests that you refer commonly in your practice to diagnose allergic rhinitis?
Yes, definitely. It's a clinical diagnosis always. Always look for the hidden signs like turbinate hypertrophy, deviated nasal septum, or Denny Morgan folds under the eyes, long eyelashes, wrinkling, dark circles, these rubbing things or derriere line, cervical lymphadenopathy, posterior pharyngeal hyperplasia, halitosis, white coating of tongue, then protruded jaw or protruded teeth, upper caries teeth. These are the hidden signs and clinically. So it is always clinical. Definitely, the research has been happened that rhinomanometry, anterior rhinoscopy should be done in some of the patients, but the standardized skin allergy test should be done in all the patients. Skin allergy test, why I mentioned, because it picks up the mast cell bound IgE rather than the circulating IgE. Very few patients which have a food allergy also in these, they only may require an advanced component resolved diagnosis as a food allergen testing. But most of the patient, the standardized skin prick test can pick up these allergens. So these standardized tests can be done. Then theoretically or research based nasal eosinophil count, even the cough or the mucus which contain from the upper airway, that also can be measured with the eosinophils and all. Those are there, but practically they are not done. So these tests also can be done.
All right, sir. And you had mentioned precision medicine. So, where do you currently see immunotherapy or biologics being used for allergic rhinitis? And how practical is it in the Indian scenario?
Actually, biologics and probiotics are the future therapies in allergy management. Those patients with moderate to severe persistent rhinitis with comorbid nasal polyps or significant blockers nose affecting the rhinoconjunctivitis, very severe rhinosinusitis, or leading to the severe asthma exacerbations, where the patient is not getting control with the standardized therapies, even add-on montelukast or inhaler therapies and nasal steroids and all, then we can think about those patients which require oral repeated antibiotics or repeated steroids or parenteral steroids. There we are using a biologics like omalizumab, mepolizumab, benralizumab, dupilumab, tezekimab. These are the biologics as a targeted therapies. So Indian scenario, because of the affordability and all, it's slightly difficult. But nowadays the good part is last 2 years it has been covered under the Mediclaim. So that also can be utilized to improve the quality of life, to reduce the inflammation, to reduce the exacerbations, and to stop the further progress also. And then desensitization, allergy vaccines, allergen immunotherapy, or tolerance development is the only disease modifying therapies to stop the progress from nose mucosa to the lower airways to the systemic effects of allergies. These allergen vaccines we introduce against the dust mites, pollens, insects in a very diluted, in thousands of dilution, and slowly introduce as a subcutaneously or sublingually, and that built up concentration is achieved to that level where the patient, if he is exposed to the allergens, you should not develop a reaction, rather than the tolerance should be developed. Then the maintenance therapy is given for 18 months to 3 to 4 years that way. So these are the very good precise medications and which can be used to stop the progress of the disease.
Thank you, sir. Another question is, in terms of adult patients having allergic rhinitis, how comfortable are you using the combination of intranasal corticosteroids with intranasal antihistamines for short term, and how comfortable are you for long term?
Even about 6 years also I am using. As I mentioned, the rhinoconjunctivitis is very common in children.
Yes.
It is disturbing. So there we are using for 3 to 6 months also, depending on the exacerbation. Many of the patients in the winter or summer, they have a problem. Adults, so it's very safe. We have used very well. Only the technique is important. If it is not used properly, then it goes to the postnasal and it causes a lot of throughout the day bitterness and irritation and some nausea. So properly at the only nasal terminates, it should be used. It can be used for a longer period also. No problem.
All right, thank you, sir. And we'll be winding up shortly. So, in your clinical experience, sir, have you seen efficacy on par of mometasone with FF?
Yes, actually, mometasone, as I mentioned, it is very good molecule, and I have used it very regularly in most of the patients. It has shown a very good results. Even FF is also very good. I mean, both are compatible. Systemic bioavailability is lesser with the mometasone, and which has been studied for a longer period. Both are very efficacious, definitely.
All right, sir. So maybe similar efficacy, but
Yeah, yeah.
safety would be higher with mometasone.
Mometasone, yeah.
All right, sir. In 2 minutes, if at all we get any more questions, otherwise we can wind up. So for immunotherapy, sir, do you prefer sublingual immunotherapy? Do you feel it may be on par with injectable?
Actually, both the therapies 2013, we are lucky that in India only, Hyderabad, the World Allergy Organization meet was there, and there is a documented position paper of World Allergy Organization. It has shown that both are at par, though both are efficacious. Only the subcutaneous immunotherapy has been used for a longer period,
Yes.
since many years, and that's why in Western countries it is very comfortable and the people are using there. But in Indian scenario now, 90% of the allergists are using the sublingual immunotherapy, and we should be very proud that now this year the tablet form sublingual immunotherapy has come for the dust mites.
Yes.
Maybe for the pollens and all it also will come. It is very efficacious, it is most standardized, and it is very safe. It does not require any storage conditions also.
Okay.
So like a freeze or refrigeration, that's very good part. The patient can carry with them anywhere. So this type of future therapies will be really helpful to the patients.
Okay, sir. So, and final question, the role of intranasal corticosteroids post-surgery, like turbinate surgery or FASS, for example.
Actually, as an allergist, I don't operate,
Yes, sir.
but still patients come to me post-surgery
Yes.
with the problems. It is very efficacious because already because of the surgery also, there is a disturbance, there is an inflammation over there.
Yes.
And this is a localized and it controls the inflammation very well as compared to the other any of the medications. And rather than giving a oral and parenteral steroids to control the inflammation, the nasal steroids play a very important role. That's why my colleagues, ENTs, they are using a budesonide respules also added on into the this nasal wash, boiled and lukewarm water, and asking the patients to use that in
Alright.
such a high dose so that the inflammation also will be controlled. So
Alright.
definitely they are useful practically.
Great, sir. Thank you so much for a wonderful session, which was scientifically rich and I'm sure has helped to educate us all. So, with that, we can close this session. Thank you very much for joining us, sir.
Thank you. Thanks a lot.